Great.
Oh, yeah.
All right. Well, kia ora koutou. So nice to have you all here. Thank you for taking some time out of your day to join us for this webinar in our series, Sexual and Reproductive Health over the Life Course. I'm super pleased and honored that we have Deborah Bush with us today, and she is going to talk about early intervention for endometriosis and why it matters, and a little bit about her program, What About Me? So before we get started, just a few housekeeping things. If you could please keep your speaker on mute during the presentation. After Deborah is finished, we will have an opportunity for Q&A, which I will moderate. You can just raise your hand like this, or you can use the little system within Zoom. Next month, we will be having a webinar. The date is yet to be determined, but keep your eye out for that. We'll be hearing about recent research in Kiribati on sexual and reproductive health, barriers to access, etc. So with that, I am going to hand it over to my lovely colleague, Sue Reed, who will do our welcoming karakia.
Oh, kia ora Ragnar, kia ora everyone. Kia hora te marino, kia whakapapa punamu te moana, hei huarahi ma tātou I te rangi nei. Araha atu, araha mai, tātou ia tātou katoa, hui e tai ki e.
Thank you so much, Sue. So now I'd like to introduce Deborah a little bit more. She co-founded Endometriosis in New Zealand in 1985. She developed the world's first menstrual health and endometriosis program called What About Me? This is for schools, for continued medical education and workplace programs. She has challenged government policy to develop the clinical pathways for treatment and management of endometriosis in Aotearoa. Her private practice, which is EPP, Coaching and Consulting, integrates into endometriosis centers of expertise. She is founding principal of World Endometriosis Organizations, and she is senior advisor to the World Endometriosis Society. She sits on 2 Health New Zealand councils. She has obtained many national and international awards, which reflect her contribution to this area and her achievements. So with that, I'll hand it over to you, Deborah. Thank you for being with us.
Kia ora, Ragnar. Thank you very much for that very nice introduction. I'll just do a very brief mihi. Ko titihi o kahukura toko maunga, ko Takaro toko awa, ko Charlotte Jane toko waka no tautahi hau, ko whanganui a tā rā toko tūranga waiwai. No reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. I'm just delighted to be here today, but I'm not so pleased for you because you're going to have to listen to this really croaky, not very nice to listen to voice at the moment. It rides the back of a nasty flu about 6 weeks ago, and it's just lingering as a really annoying cold. So I apologize for my voice, and we'll get started. Okay. So just looking for here we go. Just a few disclosures, none of which are really relevant to today's presentation. And I thought, because it's endometriosis for me is a topic that we could, well, I've just come back from the World Congress in Sydney, so 4 days, and we're going to do this in an hour. So I thought what we'd do is just maybe divide it up into 3 parts, and we'll look at, you know, what really is endometriosis, and you know, how many of you would like to actually quickly go over those things? What are the symptoms? And for the same reason, you know, to really just make sure we understand this horrible disease, and then look at some global statistics and research, and particularly as they relate to young people with endometriosis. We'll look at some clinical guidelines, and then we'll look at early intervention. So lots and lots to get through. And with that, I'm just going to bring up this wonderful painting that I saw in the Rijksmuseum in Amsterdam when I was presenting over there. And I took one look at it and I thought, betcha, she's got endo. She's pale, she's wan, she's young, she's doubled over in pain. The physician is standing there feeling her pulse and thinking, well, that's normal, you know, get over yourself, or whatever they said in those centuries ago. And I think for me, this is really confronting, because many of our young people are facing exactly the same things today when it's not necessary. And that's why I thank you for attending, because the more we understand this disease and understand its significance and its prevalence, then the more we can do to help our young people and our communities understand. So the painting is actually called The Sick Woman. And I want to start with something that I think is absolutely beautiful. And this is a piece from Ngahuia Murphy's work. And it looks at how menstruation was perceived before colonization. And it was a beautiful thing to be celebrated, because without, of course, waifero or red waters, we wouldn't be able to procreate. We wouldn't be able to, you know, continue our species, our human species. And I just want to mention this, a flowing rhythm, an ancient ritual. Waifero derived from the earth herself as she dreamed of the teeming multitudes of creation. So it's beautiful, it's positive, but unfortunately, for many, many people over many centuries, periods haven't been like that. In fact, they can cause extreme chronic pelvic pain, and dysmenorrhea is just the word that we call painful periods. And why do I think endometriosis is the most important? Well, aside from gynecological cancers, there's lots and lots of things that cause pelvic pain. And you can glance your eyes through the list and see. And some of these symptoms actually overlap with endometriosis. But here's why. Because the disease starts young, because it's so prevalent, and we'll have a look at that in a minute, and it can be life-altering for a lifetime. And for that reason, I think endometriosis is a key factor today, and a major public health issue that needs far more attention and funding. Just a quick overview of what endo is. So I'll put my cursor on the inside lining of here of the uterus. So it's a chronic inflammatory gynecological condition where tissue similar to the lining of the uterus is found growing outside of the uterus in places where it shouldn't be. Now, it mostly affects the female pelvic organs and the pelvis, but it can be found in other parts of the body. In fact, the spleen has been, up until recently, the only place where endo wasn't found, but we now know that that's not right either. So in all places of the body, there is research that indicates endometriosis has been found there. Commonly, other sites may include the diaphragm or areas in the upper abdomen. But I've also had a patient who had a nosebleed every month. These things are rare. I think if we say only confines it to the pelvis, I'm just raising it for you as to let you know, well, it usually does, but it has been found outside the pelvis too. The other thing that goes along with endo is adhesions. So we get bits sticking to other bits that shouldn't be stuck. And when that happens, it makes everything immobile, and it can cause pain as well. So adhesions are common. So what's this thing called adenomyosis? Well, we know endo is tissue similar to this, growing outside the uterus. Adenomyosis is found as the same, but it's found in the muscle of the uterus. So you can have both conditions. Just quickly, you might have had people you know, or clients you've seen, who tell you that their disease was staged. It was stage 1, 2, 3, or 4. And that's an American staging system. We know it's terribly flawed, actually. But what it tells us is the clinical stage of disease. It doesn't tell us how bad the symptoms were. And in my experience over 40 years, and particularly working with young people, young people tend to have mild stage disease, but quite aggressive symptoms. So I think it's really wrong, and I feel quite sad when people say it was only stage 1. To that person with the disease, it was life-altering and debilitating often. So how do we know I've got endo? Well, here we know we've got some symptoms. So I think it's quite good for us to be able to say, while it's subjective, discomfort can be normal, but distress is never normal. So distress with a period, in other words, ever in the sick bay, I'm talking about school-aged people now, ever in the sick bay, ever off school, ever don't do things with your family and friends because of a period, that needs investigating. So I don't need to read all these out. You can look at this side of the list and then this side of the list. And I'd like you in your own head to think there's something major missing. There's something off the list. If we were in a situation where I could see you, you'd probably be put on the spot. And for those of you who've recognized this is, of course, the bowel-related symptoms. And in fact, many people have been to the doctor, and I have patients who say to me, oh, well, no, I didn't really get symptoms but I was diagnosed with IBS in my teens. And that is key. So if we look at this disease globally, please, not just as a bad period, but globally, how has it impacted you? What are the bowel symptoms like? Does sex hurt? Because I've brought in our big guns now. And with that, I'd like to introduce you to my dear friend and colleague, Mr. Michael East. Now, he's got some diagnostic bell ringers. If you're ever hearing these things, so what's always abnormal? Menstrual distress, mid-cycle distress, pain going to the toilet, pain moving your bladder, pain with sex, always abnormal. And I think sometimes we normalize things because, one, we might get used to them. Another way might be that parents might say to their young people, oh, you like Nana, she had bad periods. It doesn't make it right, or it doesn't make it that we can do something about it now. And pain before a period or localized dysmenorrhea or painful periods, be suspicious. So thanks, Michael. You can pop off into the wings now, and I'll introduce Dr. Ben Sharp, another very, very dear friend and colleague of mine. Both of the Ben's from Christchurch, of course. Michael is in Auckland and Christchurch. So what can be done? What tests? Blood tests. Well, there's no blood tests for endo or adenomyosis. Scans. Now, often they'll show adenomyosis because the uterus might look, I don't know whether it's a medical term, but it's used a lot, that might look bulky, and that's a suspicion that there may be adenomyosis there. But usually, it's particularly mild stage endo doesn't show on a scan, but oh my gosh, the work that's being done in Canada, in Australia, and some other parts of the world on identifying a very mild disease even is wonderful. In New Zealand, we don't have that level of expertise just yet. So don't lose hope. It's on its way. I think there's one sonographer in Auckland who's really, really good at this, and there's some others training. So that's good news. But at the moment, a scan, normal scan, doesn't tell us much, except it was a normal scan. It certainly doesn't diagnose endo just at the moment. No, for the x-rays. MRIs in New Zealand aren't routine, but they may be considered, particularly if someone has private medical insurance. And what if all that's normal? Well, what some people say, well, I'm going in for a diagnostic laparoscopy. The clinical guidelines all say we don't do diagnostic laparoscopies. I mean, going in where you might have a suspicion of endo, the patient's anaesthetized, she's in theatre, on the operating table, the team around, imagine the expense. And we look in and we say, oh, it's endo. And then we close up. So, that's a bit silly. What we know now is we can do a diagnostic laparoscopy, but we treat at the same time. So we can remove the endo, and different techniques are used for removing endo. Excision seems to be the gold standard. That's cutting it out, removing it, getting rid of it. And other techniques are used too. Sometimes a Mirena or a J-Desa placed. and looking at an MDT, a multidisciplinary approach. Choice, I'm always about informed consent. So Ben has suggested, as the clinical guidelines do, that we make a working diagnosis. And how do we do that? We're listening for the symptoms. You can be doing this too. We're listening to the story, and we're looking at the family history, and we can actually treat, and it's usually with hormonal medication as a first line, but people might want to try other methods as well to get going. So we tend not to say these days, you need to go to surgery as a first line treatment. That tends to be around the world, the thinking that is best, and I agree with it. So why do we need to know about endo? Here, I'm quickly going to flick through this, because at least 1 in 10 have endo, and that's about 200 million worldwide. Staggering, isn't it? And what we know, Australians have done some recent studies showing 1 in 7. That's the data that they're using. I'll move on quickly. We don't have the statistics exactly for transgender and non-binary individuals, so they tend to be grouped into that 1 in 10 cohort. Up to 1 in 3 will have fertility problems, huge for this disease. What about the diagnostic delay? 8.7 years in New Zealand. Not good enough, is it? That was our data that we released 2 years ago. You're 7 to 10 times more likely to have it if an endo relative have it. And here's the thing. What does it cost in Australia? 7 to 9 billion per annum, and 88.2 billion pounds in the UK. That's where I got the references from. But here is this, I think, will knock your socks off, because this is our recent study. It's yet to be published, so this is a preprint. I am an author. I do have approval from the other authors to share this with you at the moment. But what's the real cost in New Zealand? Now, this lineup of authors may not mean much to you, but we did, some of them are medical economists. So these results weren't just from a survey of patients or individuals. The numbers are crunched, and if anything deserves the recognition of our health decision makers, it's this data that I'm going to release to you right now. And that you might go, well, I don't understand that. And I totally get that. So I've put this little list down for you. The lifetime burden for endometriosis per individual is 3.5 million New Zealand dollars. That's per person. And it's 2.74 per person with chronic pelvic pain. So how that was worked out was over a 34.5-year working lifespan. So over 34 and a half years, it costs 3.5 million. Now you could say, well, I've got endo and it didn't cost me that. We're looking at productivity in the workplace, all those things over a 34.5-year. And so it was just adjusted for labour force participation. We're about to release this when it's published, but let's look out for it. Many barriers that women face, and if you're sitting there or listening to this with endo, you will know them. How many times did I go to the doctor? How many times was I told it was normal? How many times was I told it was all in my head? How many times? And you've probably, as I've done a bit of a babble on that, have been able to read the barriers to effective care. And I think, what are the barriers in New Zealand? Because we do have a unique set of barriers ourselves. And one of them is just accessing public health for endometriosis in New Zealand. It's burdensome and it's chronic. Let's look, and I want you to read through these. I'm not going to read them all, except I will read this middle one here. I'm so hurting today. It started off abdomen pain, and then the pain spread all through my stomach and the back of my legs and my lower back. Literally a crier tonight. Nothing is working to help the pain. I'm tucked up in bed all day, fidgeting to get comfy. It's a mean disease. And I'm sure by now you've read the other patient feedback. It's a very nice study. I won't dwell on it, but looking at from a very world-renowned authors, unable to achieve education goals. Look, strongly agree. So missed work, lost a job, unable to fulfill full-time work. So, a lot of that there that you can see. Quickly moving on. And what about dysmenorrhea or painful periods in our young people? So I've chosen this study, that there are many, many, of just over 4,000 in the cohort from Australia. And if you glance down this side, look, 92% of them said they had experienced dysmenorrhea or painful periods. And if you go down, you can think, really? Well, that stacks up in the world literature as well as our literature in New Zealand that was I was the lead author in a study that was published. I'll show you it in a minute. But this is the impact of this disease. And here's another. So the conclusion I will read to you. The prevalence of dysmenorrhea was high, irrespective of country, with dysmenorrhea having a significant impact on academic performance, both at school and during higher education. And that's how those numbers that we saw before are crunched. So what do the guidelines say? Whoa, we're on to part 2. Here we go. Now, I've just we're going to quickly look at these. I've selected some guidelines. So this is the one that I was persistent on. I think I became a pest to the ministry at the time, that we had no clinical pathway in New Zealand. So 2015, I put this group together, including the ministry and RANZCOG and our medical colleges and people with endo, and we finally launched that in March 2020, just before COVID. That was annoying. All right, so there's the RANZCOG guideline, the Living Guideline today, the NICE guideline, consensus on the current management of endo, and the ESHRE guideline. And what they all say, I've just selected one thing that is evident to all, although there are many commonalities, and it's this: recognize the symptoms early and intervene in a timely manner. How basic is that? Recognize them early and intervene in a timely manner. They also acknowledge that a multidisciplinary or interdisciplinary approach, they couldn't make firm recommendations, and they just said more studies are needed. But I'm a firm believer in that approach, along with many of the colleagues I work with here and around the world. So, sorry. Oh, whoops, I said, I think, that I was going to warn you when this slide came up. Oh, well, sorry. We're going to dive into the pelvis and have a look at what endo looks like, because, I mean, we talk about it, but what does it actually look like? So I've got 2 people here. I've got Laura, who's 15, and I've got Lisa, who's 33. Laura had stage 1 endo, and there it is there. You will see a patch of red. Now, I've gone through and I've labelled all the bits, but I do thank Mr. Michael East for giving me this photo. And the one of Lisa as well, not their real names. So you can see stage 1, here it is. Lisa was off school 3 months. She had intensive mental health therapy because no one understood that she was, when all the tests came back normal, that she might have had endo. She did have endo. This was her second laparoscopy that was found. And you can see it there, patch of red. There's some more in the pouch of Douglas in here. But look at Lisa. She had to just to have a look at some anatomy here. Here's the uterus. There's a nasty plaque of endo on the bladder. Both ovaries are engorged with what we call endometrioma, or cysts of endometriosis on the ovaries. You can see all the adhesions that we talked about. This is advanced stage disease. So let's look. I'm going to ask you a question. So in your mind, I can't see you, but in your mind, put your hand up if you think Laura had the worst pain. And now put your hand up if you think Lisa had the worst pain. I can see some hands going up for Lisa, but I didn't see any hands going up for Laura. And there'll be some of you who don't know. And the truthful answer here is we can't tell. Endometriosis is the pain is subjective, and we know that young people with stage 1 disease can have excruciating pain. Lisa, in fact, presented with fertility problems, unable to conceive, not with pain. All right, so what about this? Can we stop that? from becoming that? Well, let's see what we did. So could early intervention, and this is really where I want, we're getting to now that I want you to concentrate on. If we intervene early, can we do these things? Can we improve health outcomes for our young people? Can we halt the disease progression? Remember, stopping it from getting like Lisa's. Can we stop the disease becoming chronic? And what do we mean by that? Pain on most days that's lasted longer than 6 months. So that's when things become chronic. And that's why if we intervene early before it becomes a horrible, mean, nasty chronic condition, we tend to be able to treat better. Can we protect future fertility? We don't know the answer to that one, but I believe with early intervention, we can certainly make a difference in those other ones. So here's the ME program thank you, Ragnar, for introducing this. ME stands for Menstrual Health and Endometriosis. I actually introduced this last century because I couldn't believe, despite what the literature said and the Time magazine said that endo was an old person, well, not old. Endo was a disease affecting older women and only career women, not Māori, not African, not Asian women. In fact, it was a white woman's career disease. Well, 2 letters for that, and the one is B and the other one is S. So let's move on and have a look and see. Right, so I did the first pilot. This wasn't easy. You can imagine, can't you? You're really bucking the system. But I could tell from the people I was listening to and the seminars that we were taking, this disease started young. So as a person with a teaching background, I started the ME program in schools and always made it medically responsible, interactive, and age appropriate. So here we go. We're going to whiz through now. It was being trialled in Mumbai and British Columbia and South Australia and Ireland. It reached in New Zealand over 400,000 students, and we went to approximately 100 schools a year. Schools requested it back. Once they had it, they requested it back year on year. Students loved it. It was a mixed method delivery. It went as we could. We were guided by the schools, but absolutely promoted that it went to all students of all genders. And we accommodated that in the program delivery. This was from 2012, and it looks at the World Health Organization as a planned approach to an education program in schools. So, it's just not good enough to get a whole bunch of slides and a couple of rotten stories and deliver them to our young people. That's not a program. It has to be pedagogically assessed as well as medically. And I'm a firm believer in this because I've seen some things. We don't need to scare our young people with horrible, scary stories about menstruation when it's such a normal, natural thing. From this study that was published in the Australian New Zealand Journal of Obstetrics and Gynecology, we found that 27% of our young people miss school every or most months. This is New Zealand data. I was much younger then, but that's the ME program was endorsed and the only program in the world to be endorsed by the World Endometriosis Society. It's been included in the National Action Plan for Endometriosis in Australia and referenced all over, including in the RANZCOG guidelines. So look, what happened in my, and I'm going to switch hats now and go to my own private practice, EP coaching and consulting, and look at, because this was the ME program had a rollout of 20 years in Canterbury, other places too, but that was the mainstay. So I'm based at Oxford Women's Health for my EP coaching work. Starting in 2001, just follow this line up. This is the number of people who were referred to me. 12% in 2001, just as the ME program was getting going. Up here, bit of a drop off, whole bunch of earthquakes, sorry, lost data, couldn't keep things going then, picked it up again. And at the end of 2019, that's when I stopped the study, the 12% had gone to 62% of the patients referred to me were under 20 and saying that they'd heard the ME program at school. There's the power of education. It's incredible, isn't it? And we were able to intervene early, appropriate, age-appropriate treatment and management, and it won't surprise you looking at the list of symptoms that most of those young people had. Right, so how do we get on to shifting it online? Well, in 2019, here's what's lovely. Isn't it lovely to get feedback that you think, oh, the schools are loving it, the students are loving it, I'm doing so well, everything's honky-dory, but at some point you need to actually really assess it for efficacy. Does it still fit? Is it still purposeful, delivered this way? And that is going from school to school to school, much like the Encyclopedia Britannica salesman in the days gone by. So, and my job was to actually dust those encyclopedias on a Saturday. We weren't really encouraged to use them. All right, so that's digressing. Here we go. So we assessed it. And I was staggered to find some things out that had been that really did need our urgent attention. And it coincided with COVID, our lockdown time. So this just tells about what the study looked at, that we reassessed it, and now we'll move on to saying what were some of the results of the study. So we only chose schools that had had the program for more than 15 years, because that gave us a really good longitudinal viewpoint. And it wasn't, we just love it, we want it back. It was saying, yes, we do want it back, but actually we'd prefer an online resource. And of course, I understand absolutely that this came in the middle of COVID, and of course that this was the thinking of teachers. But when I looked up the pedagogical evidence, that's exactly and it starts at 2013. And it looks and says, one-off programs that go into schools one by one are not as good. It should be teacher information to the students that they work with closely. And I think that this particularly relates to subjects like this that are intimate subjects. I also found some things about, because students were involved too. Do you know one of the things you might see down on the list here, climate change? What has that got to do with an in-schools endometriosis program? Well, some of the students, no teachers, but were putting, we don't want to support a program that goes with a fossil-fueled car around all the schools and has hard copy that we're going to turn into paper planes and throw around. I think that's fair enough, don't you? The thing that was most staggering to me, and something that I thought was completely irresponsible, was that 80% of philanthropic funds that we got to run the program went in administration. Not good enough. So we turned it online. And here's the result here. So this was from a poster that I did for a conference in Edinburgh, looking at why we turned the Me program into an online program. You can read this part here, but also I want you to take some pieces of this puzzle out and just look at them here. Medically responsible, parents, teachers, students, you can see what you're getting. You know what your young people are being delivered. It's engaging, it's fun, it's got lots of interactivity and gamification and things. There's the e-learning thing. I'm going to move on now in the interest of time, but you can see, whoops, here we go, that in the conclusion, menstrual health education cannot be left to chance. I even get a little bit emotional about this, because I've seen where it has gone wrong and how it's gone wrong. And the last thing we want to do is disrupt the learning and the appreciation of bodies doing things they are meant to do by delivering something that's scary to a very vulnerable audience. And at the same time, we need to also be making sure that they understand symptoms that stray from the norm are not normal, and that something can be done about it. So we need to prepare them, I think. I'll read this out. To navigate a range of experiences from their very first period through their adult years so that they can be actively involved in their menstrual and reproductive and sexual health now and in the future. So the program, look, this is just some screenshots of what there. You can drag and drop these organs into the right place. You can tick boxes. We use Te Whare Tapawhā. You can drag and drop these things into the right place and do a checklist for yourself. There's a great little, I think this is the best little 2-minute clip about what a period is. There's young people, some younger ones, sort of 13, 14, 15-year-olds, and then these older students talking about their experiences. Just by chance, really. There's one of them was transgender. We didn't ask, we just asked for a group of people who would like to be involved. You can click on things on the body and look at symptoms. So I encourage you to go in and have a play. I think you'll love it. It's very New Zealand, so it uses a lot of te reo Māori. We love it. Here's the landing page. You can contact me from up here. This is just a screenshot, and all of these people donated their time. We didn't buy beautiful images of people. We actually did a photo shoot in Gisborne. So you start the course from up here. This is just the landing page. And I love what about me? You can say, what about me? Goodness sake, listen. Or you can say, what about me? What about menstrual health and endometriosis? What are we doing about it? And this is what's happening in Ireland. So I love what they've done with this. I've been working with this team for 2 years now. So Misha means me in Gaelic Irish. And they've also used the analogy of menstrual information, specializing in endo. So I just want to show you what they've done, which I'm so proud of it. So they've used the Irish Gaelic word. They're going into schools. They've got some great feedback, and now they're well underway. And this is the feedback that we also got from, excuse me, our young people. What about some patient vignettes? I'm looking at the time. Okay, we're going to do this super quickly. Patient vignettes are just wee snapshots to show you what this is this year. A group of people. I've chosen a 19-year-old and some other people from different age groups. How many, diagnosis at 17. So onset of symptoms 9. Each patient vignette follows the same thing. How many consultations have I had? What's my current situation? What I would like. A 19-year-old says, I'm over it. I don't know. A 22-year-old said it took 5 years to diagnosis. What she would like, help getting over the anger of being disbelieved for over 4 years and help to relieve my anxiety about my future fertility and period fear. These young people develop a fear of getting their period. They're working their lives around it. That's when my exams are. I've got an assessment then. I can't go for that sleepover. All of those things. Sometimes we just don't think about the impact, but they're real. What about our 31-year-old, 5 years to diagnosis? I'll read this out because here's who she's been to. 2 GPs, 3 gynecologists, 4 counsellors, 2 urogynecologists, 2 rheumatologists, 2 acupuncturists, 3 chiropractors, 5 naturopaths, 1 endocrinologist, 2 pelvic floor physiotherapists, 2 physiotherapists, 5 massage therapists, 5 laparoscopies, 3 3 excision, that's removing the disease, kind of gold standard, although our gynecologists tend not to like that word very much, and where the other one is burning it off. A fertility specialist, what does she want help with? Help to re-engage with relationships and dietary advice. Incredible, courageous people. What about our 40-year-old? Same line, like you can glance around and see what consultations she's had. 8 laparoscopies, 1 to remove her appendix, an emergency C-section. What she would like, manage pain around a full-time job and family. Actually, ways I can articulate to them what this has meant to me. At the World Congress on Endometriosis, not a good shot, but I was asked to speak about a multidisciplinary approach, and particularly with regard to what's happening in New Zealand. I was on a panel with Bangladesh, the Philippines, Puerto Rico, and Australia. It was quite intense and robust and high-powered, and we were all on the same page, basically saying the same things. We need to do way better. And so in 2020, I introduced my, no, I didn't, in 2000, sorry, there was a distant one digit out, my EP coaching, or endometriosis and pelvic pain, because I thought there's got to be something better that we're missing that sits between our patients and their health professionals. And I started EP coaching. I now run it through 3 clinics: Auckland Gynae Group, Ascot Hospital, and Oxford Women's Health in Christchurch. And I'd like to acknowledge Mr. Michael East and Professor Neil Johnson for always supporting it. A lot of other gynecologists as well, but they've been there from the outset. People love it. Look, what was this about? Only 42% were influenced to try lifestyle management offered to them in the EP coaching. A lot of the patients I see now, remember, are young. They just want to get on with things, and so they did. So it's sort of not surprising, but I love 100% had a sense of well-being and hope following the clinic. And I'd like you to read some of these things down here. It provides me with reassuring support. It was great being able to understand. It was so beneficial. I'm stoked. Listens to what you have to say. That's part of listening to the story that I do. And here now, we've got the proof that EP coaching is wonderful. We released this study, and I'm an author here as well, on the consensus on the management of endometriosis. How do we set up these centres of expertise? So we centered this, and this image is from the thing. I don't know whether you're familiar with research, but this was a modified Delphi version. So I think there was something like 50 authors. Can you imagine getting everyone to agree? So it was 2 years in the making, this piece of research, but we all agree it should be a multidisciplinary patient management. And this is where, with the consensus, I was just one of many, where they're placing the importance of the coach, person with endo, her GP, her gynecologist, and well health coach as part of that. And if any would like to talk to me further about that, I'm starting to look at training other people, and I've got things on the go at the moment with that. But yeah, we think involving the dietitians, the allied health professionals, we call them, is the way forward. And there's a link there that you can go to see the paper if you would like. Lastly, here is I chummed up, if you like, not financially, I want to make that very clear, with this person, Juliet, who founded Endo 45. And what this is, this Endo Fit. It's a guided help for those with endometriosis. I had a little trial of it. I mean, I'm so menstrual out now, it didn't work for me, but I still was able to go through. And, for someone with endo who's truly stuck, I believe that $70 for a year to subscribe to this really keeps you on track. It helps you navigate our health system in New Zealand. It is all peer reviewed, and I really, really like this app. There are many apps, but I like this app, particularly given that it's peer reviewed and by gynecologists and doctors in New Zealand. And I commend Juliet for her work with this. And that brings us to an end. So ngā mihi nui. I'd like to really pay tribute to and thank my colleagues in New Zealand and overseas who have supported and contributed to my mahi, as well as the World Health Organization, who say, let's make sure every person with endometriosis gets the diagnosis and the care they need to manage their symptoms. It's a matter of health, of well-being, and human rights. And I'm currently working with some authorities to see if we can make things better in our country for those with endo. Ngā mihi nui.
Thank you so much, Deborah. That was a like a whistle-stop tour through so many different aspects of well, of this disease and how it affects people's lives, as well as the work that you've done and the approach that you've taken with education in particular. I want to open up the floor for questions. So like I said, you can just raise your hand if you have your video on. If you can turn your video on for this portion, that's great. Or if you are able to use the react and under the little heart react, then you can raise your hand there as well. Any questions for Deborah?
No.
Oh, Woody, please go ahead.
Oh, kia ora. Thank you for that. That was great. I just wonder, because there's some amazing resources and stuff there, but most of that would need funding. What is actually available for our young people or sufferers that have no health insurance and even struggle to access a GP?
In some ways, Woody, I'm kind of silent. Because we were making huge headway, and to get this across the line in 2015, to set up the clinical pathway for endometriosis and get that across the line, then to have COVID fit, come and destroy things just as we were launching it in March 2020, really did put the kibosh on things. And then, as you know, the health system, as things moved, it was never truly properly implemented. That leaves our people without health insurance vulnerable, as you say, often unable to get GP help. There's very few tools that our GPs have at their fingertips, and many have exhausted them all. And I'm not answering your question, I know that, but I'm adding to it, if you like, by sharing my frustration and saying that what happens is that when they do refer their patients, they frequently get, after some time, a letter back that says, due to capacity issues, we're unable to assess the patient. So in most public hospitals in New Zealand, patients with non-cancer gynae issues and conditions are simply not seen. They're referred back to their GP, who has often already exhausted everything. However, the clinical pathway is available to you when you delve deep into the bowels of the Health New Zealand website and find it, and it will give you the ideas for, and it does need upgrading. It's 5 years old now. I acknowledge that, and we'll be doing something about it. But but it shows you, what are the things that I can do for me, and this is where that app is actually quite handy, because it looks at what are my bowel symptoms. If you've got a patient or a client you're working with, listen to the story, listen to the symptoms. Are the bowel symptoms major? Because if by seeing a dietitian or following some of those dietary advice, those dietary suggestions from a dietitian who understands endometriosis and irritable bowel disease, reducing those can bring about huge relief. Really understanding and going to the doctor with the symptoms and saying, what else? A clinical psychologist will often help. A pelvic physio, when you have developed, the disease has become chronic, the pelvic muscles will go into spasm. And so, maybe that can be an avenue, and maybe it's trying all of those things. But I suggest that if there are any things that you would like specific help with a specific person, you're very welcome to contact me through the Period Health website, and I'll see if I can help you any further with that. And I'm so sorry I'm unable to be more helpful in my response to you.
Thank you for your question, Woody. Does anybody else have a question they'd like to pose or comment they'd like to make? Yes, Izzy, please go ahead.
Got it, Deborah. Thank you so much for your kōrero. I got a lot out of that. I would love to know when that study of yours on the cost of endo and chronic pelvic pain, the burden of that, when that's going to be released. If you have that, if you have a date.
I don't have a date. I have a it's in preprint. We've had a dialogue and with the publication itself. And let me see. I think it'll probably be picked up by several avenues in the media. There's been quite a bit of noise recently from the media. We would hope within the next few weeks, but maybe it'll be stretched out a wee bit longer than that. But once again, if you want to contact me, and you can then go in my inbox, and I don't get anyone out of my inbox until I've responded. But if you would like to do that anyway, it's just that we have to be, because it's only preprint, we have to be careful about releasing, the whole document at the moment. But I'm happy to share a little bit more in confidence with you.
Yeah, I would love to spotlight some of the information that is in that study.
It will be in the media, believe me.
Yeah, cool.
Thank you, Izzy. Anyone else have a comment or question? Okay, well, I'd like to.
Sorry, maybe just a subsequent question.
Mhm.
Deborah, are you aware of any potential review happening of the New Zealand Endo guidelines? I know that there are some calls from the kind of consumer sector at the moment to have those guidelines that were published in 2020 updated and reviewed. And
yeah, there's several. I'm very aware of what's happening in the media with two patient-based organisations, and one calling that we should be introducing the Australian guideline here, and the other organisation calling to upgrade the clinical pathway. Just to clarify that, it's a clinical pathway, so it's not a formalised guideline like the RANSCOG guideline is. And when you look at the clinical pathway as it exists and acknowledging that it needs an upgrade, it actually sits alongside all those guidelines that I introduced there across Europe, the UK, and Australia. So it sits alongside those, even though it does need an upgrade. I have a problem with adopting a guideline from another country that isn't New Zealand specific. For instance, the RANSCOG guideline, if you open that guideline up on the first page, it said it was developed for Australians, for the Australian setting. There is no n's in that RANSCOG guideline.
yeah,
So it also talks about our First Nations people. And I'm wondering, the people who are calling for this understand, what are they wanting? To just complete swap out First Nations people with our Māori? To me, that's reprehensible that we would even be thinking that. So maybe I'm overstating it, but I feel very strongly about that. The RANSCOG guideline for the Australian setting is fantastic. And so I want to acknowledge that, but it isn't just a direct swap, as I'm sure you'll appreciate, Izzy. And I think, so therefore, I think that's misleading. And I think it would be incredibly expensive. Can I just tell you that there was an excess of 100 million in Australia to get to that point of expenses spent to get to the point of developing that living guideline for Australia. So we're not even, when we did the clinical pathway and took 5 years, we got a nice cup of tea and a plain biscuit.
The funding landscape here certainly is very, very different, isn't it? Just
But
chronically
it
underfunded.
can happen. It can happen. I think the Australian guideline is very, very good. Does it meet our New Zealand need? There's a lot of work to be done.
And maybe there are ways to draw on what's good or relevant, so you're not, reduplicating work, but then also have it adapted.
I absolutely think
culturally
that's the case. But I think that we can have a specific clinical pathway that does sit alongside that. I'm actually sharing my thoughts at the moment that are not, that just within this group that I wouldn't like to see go out to the media that Deborah Bush thinks, because I'm thinking on the spot. But I do think that you can't just transfer one document from one country to another without giving it due process and thought and allowing it to go through the process as for its efficacy in the country that want to adopt it.
Indeed.
And that the fact that we could do something with the clinical pathway in the meantime while that process happens, because there isn't any money. So I'm expecting another cup of tea and a nice plain biscuit.
Anybody else? Tanya, you just put a paper in the chat. Did you want to speak to that?
Oh, it was just earlier, the one that was published in the Lancet with Jordan and Deborah with you. So I just put that into the chat just to hold the space.
Thank you.
Which one was that? Was that the one with
the cost of endometriosis and chronic pelvic pain burden in New Zealand from the national-wide survey?
Anyone else have any comments or questions? I just want to say I really appreciate all of your mahi and also kind of this focus on an interdisciplinary sort of multiple strategy approach to this problem. Obviously, it would be fantastic if there was better pathways or treatment or a way to actually systemically address this disease, because it is so horrifying and debilitating, and it feels like it's only really been in the sort of public consciousness and in the discourse for the last 10 years. I feel like that's when people are starting to even become familiar with what it is. And so many people still don't know, as per your, focus on education. So, yeah, I just really appreciate all that you've brought to this conversation and thinking about how we might be able to support people with these other dimensions of their life, since we are quite constrained for a variety of reasons in terms of our health system and what we are able to do for people who are suffering in this way from a clinical perspective. But I think also as hearkening back to a previous webinar around epistemic knowledge and kind of this belief in what women in particular and people with uterus are saying about their experiences and their realities of life. So thank you for your work.
Look, I really appreciate being here today, because I think, it's people like all of us, you and me, who can make a difference. And I think that we need to use our skills and the various fields that we're working in to make sure. And I know that your commitment and dedication and your mahi matters to all of us, and particularly in my field to those with endometriosis. And I'm not apologizing, but I do acknowledge that I'd sort of put my political hat on then, and and you got some of that. I didn't actually mean to do that. So
okay, that's okay.
And they were just my thoughts and opinions, so
Yeah.
they may be expressed with more clarity in the media if I have that opportunity to express them. We'll see. But yeah, look out for those things, and please contact me if you would like any further information or help.
Lovely. Okay, well, with that, I will now hand it back over to Sue to do our closing karakia.
Oh, kia ora. Thank you so much for that, Deborah. Sobering, triggering, all the things. Thank you very much. Ka whakaere te tapu, kia waitea ai te ara, kia turu ki whakataha ai, kia turu ki whakataha ai, homi e, hui e, tai ki e.
Mā te wā.
Thank you so
Kia ora.
much. See you all
Kia ora,
soon.
thank you.
Bye.